by Dr. Erin Mellano. Dr. Mellano, do you want to introduce yourself?
Sure. I'm very little on the screen. I apologize for any sort of technical difficulties we're having over here. My name is Erin Mellano. I am a female pelvic medicine and reconstructive surgeon or a urogynecologist. I am down here in the South Bay, kind of across the street from where Women's Advantage is. And I work for UCLA.
Awesome. Okay, very good. So, Dr. Mellano, can you tell us a little bit more about intro in terms of pelvic organ prolapse and why this is important for us to talk about today?
Sure. So it's obviously something I'm passionate about since it's what I specialize in, but pelvic organ prolapse is something that's sort of under talked about, and it's something that's very common. The actual prevalence of it, we don't really know, but what it is in general is sort of a weakness of the pelvic floor, and sometimes it's just explained as like a almost like a hernia of the pelvic floor. So when any of the muscles or attachments become a little bit weaker, you can get pressure from either the bladder or the rectum, the uterus if it's present, or if the uterus isn't present, just sort of the above organs pushing down on the pelvic floor that causes sort of a bulge or pressure in the vagina. And it actually can be to the point where it's just in the vagina, or sometimes can actually come through or out through the vagina.
Great. And just a reminder, if you are listening on, if you can just mute your microphone so that we can just streamline the interview better. Very good. Okay, so you had talked about the different types of pelvic organ prolapse. Dr. Mellano, can you share with us a little bit more about what those symptoms typically look like and accompany with those different types of pelvic organ prolapse?
Sure. So the symptoms associated oftentimes have to do with where the area of weakness is, but in general, the most generalized question for pelvic organ prolapse is, do you feel a bulge or pressure in the vagina? That question is actually pretty sensitive and specific because not many other things cause that sensation. But depending on where the area of weakness is, you may have different symptoms. Some people have bladder symptoms, some people have bowel symptoms, some people just have sort of this just weighted heaviness, uncomfortable symptom. If the bladder is what's pushing down, sometimes people will start with symptoms of leakage or frequency of urination, or feeling like they went to the bathroom, but they didn't quite empty all the way and they have to go back again. Sometimes the leakage that happens at the beginning, if the prolapse gets more advanced, the urethra can actually get sort of kinked off, and they no longer are having that leakage anymore, which they're happy about, but now they're more susceptible to like bladder infections and other things because of the fact that they don't empty their bladder all the way. On the opposite side, because that's the bladder side, you may have symptoms associated with the bowel. So people may feel like they get inability to completely empty their bowels. Well, they'll say, I have a bowel movement, but I feel like something gets stuck or trapped, or it's not coming out all of the way. Or on the opposite side, they may say, I'm not really able to control my bowels very well. I have an urge to go and I'm either not making it to the toilet in time, or sometimes if I strain, a little bit of stool will come out. So those are all symptoms sort of associated, but it depends a little bit on where the underlying weakness is. The symptoms may be different just depending on that.
Very good. And Dr. Mellano, who is at risk for prolapse?
So, I mean, so pelvic organ prolapse specifically for what I do, it's all female. So females are at risk. The biggest risk factor that they have identified is really just being pregnant. It's not even the necessarily mode of delivery. We used to think that C-sections were protective, but that's not necessarily the case. So pregnancy is probably your biggest risk factor. The other risk factors that we see are obviously age-related. So postmenopausal, some women will not have symptoms until later. So they'll be fine. Maybe they'll have a little bit of a bulge symptoms after their delivery. It goes away. And then later after menopause, they notice it more. Anything with chronic repetitive straining. So like anything with like either chronic constipation, heavy weightlifting, those types of things, those can all put you at risk. Some of it's honestly just genetics, like why one person can have 8 babies and no prolapse, and the next person has 1 and has significant prolapse. A little of that has to do with just connective tissue and that sort of thing. We have seen some people that are like really competitive weightlifters that have never had any children, but that again probably has to do with a little bit of the straining that they're doing. The obesity has been shown to be a risk factor for it, although interestingly enough, weight loss has not necessarily been shown to reverse prolapse. Although there's some data behind some people that are in the like very, very obese category that undergo bariatric surgery. Some of them do have an improvement. But primarily, honestly, you can blame your kids. It's primarily from pregnancy.
What do you think in terms of those who are chronically constipated? What is their risk for the chronic pressure and backup affecting their risk of getting prolapse?
What do you mean by that?
So is constipation a
Yeah.
big risk factor for prolapse?
So any chronic repetitive straining would be considered a risk factor. So anybody that has like a chronic cough, chronic constipation, anything like that would absolutely be a risk factor.
Got it. Okay. And in terms of treatment options, what do you got?
Okay. So there are many treatment options, which is kind of nice. And it doesn't mean you have to have surgery. In general, prolapse is not a dangerous condition. It's not an emergency. So in general, there's never a situation where you need to have an emergency surgery. It is pretty uncommon that we would ever go that way. And that would be for something that's pretty severe or extreme where, for example, somebody had like their ureters cut off and they were at danger of losing their kidneys or something. I mean, that's really not common. For the most part, we can treat things as a quality of life measure as opposed to as something that's more emergent. So the choices are, you could either just say, okay, thank you, I have some prolapse, it doesn't really bother me, which actually is not uncommon. And this is what it is, and I'm just going to continue to kind of live with it and deal with it, and it doesn't really bother me. You can do physical therapy, and physical therapy, I'm sure you will speak to this, but has some good data to support physical therapy, especially for symptoms of prolapse. So for like the associated bladder symptoms, the associated bowel symptoms, and actually for the stage of prolapse in our literature, and I know that we have slightly differing literatures, but in our literature, stage 1 and 2, so which is considered like mild to moderate prolapse, could actually be significantly improved with doing physical therapy. So it's actually a great modality. So you can do expectant management, physical therapy. There are intravaginal support devices, which some people have heard of, some people haven't. The most common one you've heard of is a pessary, which is basically like a ring that you can place, for lack of a better term, although there's a lot of them, and I have some pictures to show too. But it's something that you can place and prop into the vagina to hold the prolapse up. It is not a surgery, and while it's in place, things feel better, but it doesn't actually necessarily correct the prolapse. But it allows you to do your activities and to do things you want to do without feeling it, which is kind of nice. And then obviously there are surgical methods as well. So those are the four.
Pessary is pretty much like a shoe orthotic, but for the pelvic floor to support the prolapse.
So I'm married to an orthopedic surgeon. So I tell people it's kind of like if you get a knee injury and you wear a knee brace. It allows you to play the basketball game, but it doesn't actually fix the underlying injury. It just allows you to move around and do your thing without feeling the pain or having the problem. So yes, I agree with your orthotic.
Excellent. And so in terms of it doesn't actually fix the underlying injury, so in order to fix that underlying injury, you had talked about PT, and something that we do here at PT is we work a lot with pressure management of the pelvic floor in conjunction with your core. With prolapse, we want to make sure that we're minimizing excessive pressure on the pelvic floor muscles and being able to coordinate that support a little bit better and retrain those muscles to be able to match the pressure that they're given so that you're not feeling like your insides are falling out. And those bladder symptoms and bowel symptoms that Dr. Mellano had mentioned too, we work a lot with pressure management in the pelvic floor and making sure that we have a good support system, not only from the pelvic floor, but also the deep core muscles as well that accompany that too. In terms of the management of surgical pessary PT, tell me a little bit more about what you think about who is a candidate for surgery and what your process is in determining surgery versus PT or both? Tell me a little bit more about the surgical management and who would be an appropriate candidate for that.
Okay, so a lot of it ends up being patient driven when it comes down to it, because truthfully, for surgery, there obviously are some people that are either because of their medical problems not a surgical candidate, in which case we would not pursue surgery due to other reasons. Or if the stage of prolapse is such that, really risk benefit doesn't make a lot of sense. If they have like stage, and we divide prolapse based on how far down the herniation comes down the vagina. And if it's really not coming very far, then it doesn't make a lot of sense to do a big surgery if you're not going to notice a significant difference. But truthfully, anybody is a candidate for physical therapy. It's just that when the prolapse gets really advanced, so if people have advanced prolapse, which is called sometimes like procedentia, if the vagina is kind of everting and coming all the way out, physical therapy can be very helpful still for managing some of your symptoms and maybe preoperatively, but it may not cause the prolapse to completely revert when it gets to that degree. But otherwise, physical therapy is kind of always an option. As you know, you get to see all different stages of prolapse and all types of symptoms. Surgery, though, we typically reserve people that have what we consider like moderate prolapse to obviously the more severe prolapse, if a patient wants it. It's never something, like I said, that is you have to have surgery tomorrow, unless you're really in danger and you're like on an extreme side of having some sort of compromise to one of your vital organs. It's never really something that is an emergency or that you have to do. It's really dictated by the patient.
Okay. And I've had some patients who have been saying like, I feel the prolapse there when I go to wash, when I'm taking a shower, and I feel a little something there, but maybe they're not having those bladder bowel symptoms that you had mentioned. So in terms of a patient who is coming in and feeling palpably, I can feel something there, but they might not necessarily be having symptoms. What do you recommend for that?
Okay, so what you're saying is I feel the prolapse, but I'm not having any bowel dysfunction or bladder dysfunction.
Yes.
It's all the same stuff. So as far as what the recommendations are, so it's totally driven by how much that bothers them. For some people, it's like, well, I just have an awareness when I'm in the shower, but otherwise I would never know that it's there. Well, in those individuals, they may benefit the most from physical therapy because they may then learn some exercises and some techniques as far as just their normal everyday life that would prevent it from ever getting worse and ever developing those symptoms. Or they'll say like, listen, this is highly disturbing to me. I'm really frustrated that this is the case, and physical therapy or a pessary or a surgery all would be fair game depending on what the symptoms are. So it really depends on the severity of the symptoms.
Got it. And can you touch a little bit more on how pelvic organ prolapse might interfere with sexual health and intimacy?
Sure. So sometimes it has to do with just the way that a female perceives the pelvic organ prolapse, because sometimes it's so disturbing that they kind of try to avoid any form of intimacy because they're so nervous about it. You can have associated symptoms where people have like urinary incontinence associated with intercourse and other things. Typically, it's not dangerous to have intercourse with prolapse, but some people it's so bothersome to them, the idea that there's something coming out, that they're too anxious to be able to feel comfortable being intimate, I guess is the right way to put it. But prolapse in general shouldn't prevent you from being able to have intercourse. It's just that sometimes it is bothersome from a patient perceived perception. Now, there are times in which, like if people are using a pessary, oftentimes pessaries and intercourse don't go hand in hand. Theoretically, with some of the rings, you can have intercourse with them in place, but some of the other pessaries, you can't have intercourse with them in place. So people have to be able to take it out to be able to have intercourse. As far as what else are you referring to? Sorry, I want to make sure that I'm answering your question.
Oh, yeah, that's okay.
But just so that I make sure I give all the information. What else are you kind of wondering about?
Yeah. So what about in the instance where a patient might be feeling a little bit more like something jostling, uncomfortable as they're having intercourse?
Mm-hmm.
Would proceeding with intercourse be something that would weaken or affect a prolapse?
No. If that's your question, is it going to hurt the prolapse somehow? No.
Okay.
Is it going to hurt them? like just the act of having prolapse and then having intercourse, no, it won't hurt them, nor will it make their prolapse worse.
Great. Great. And then in terms of a pessary, can you tell us a little bit more about how you fit for pessaries in your office and different selections, and in terms of hygiene and those practices, how does one properly use the pessary?
Sure. Do you want to, because you asked me to kind of give you a couple slides of pictures of what they look like.
That would be great.
I don't know how to share my screen actually on this, because as you can tell, we're sort of technologically challenged over here. Is there a way to share my screen?
Yes, I believe you go on the bottom here.
I got
should
it.
have an option.
There we go. Can you guys see my screen now?
I still see you.
Wait,
I think it's.
Try this. Can you see it now?
Yes.
Do you see it?
Yes. Yes.
Okay, you're seeing my screen. All right, perfect. So let me just make this like slightly bigger. And I'm sure there's a way to make this go into, well, I'm just going to use this because this is easier. So to do pessaries, can you guys see this all okay?
Yes.
I think this is presenter mode. Okay. So these are just examples of pessaries. This is not all of them. Oh, this is going to just fast forward here. There we go. This is not all of the pessaries, but these are some examples of them. The most common pessary is the one that you're going to see on the left of the screen there. That's called a ring with support. And it kind of looks like a diaphragm with holes in it. And it's a little bit more rigid than that. It's the type that we typically use for stages 1 and 2 prolapse, which means it's a little bit less severe than having the uterus or bladder or rectum coming really far out of the vagina. But this is the most common pessary used, and it can be self-managed, meaning that patients can take it out themselves. It doesn't mean that they will, or it doesn't mean that they necessarily can just physically with their own anatomy. But in theory, they can take this out themselves. The other pessaries you're seeing on there, the top row are kind of the rings. And then the other one that's probably the second most common pessary we use is going to be in the bottom row. And it's the second one over from the left that looks a little bit like, a plunger, I guess. But it's got like the stem sticking up and it's got a little circle at the bottom. And that one is typically more successful for more advanced prolapse. And it's a little bit harder to take out and self-manage just because it kind of gets suctioned up to the top, and that's sort of how it works. And actually you can kind of see how these ones sit there. And so the suction is a little hard to release, and so it can be a little bit more challenging to take out. It doesn't mean it can't come out or a patient can't self-manage it. It's just harder to do. The pessaries generally for getting fit, we usually fit them in the office, and there's kind of a couple of criteria you have to meet. They have to be comfortable, so you shouldn't really feel that it's there. Yes, when we put it in, you can feel it going in, but you shouldn't really feel its presence once it's there. And it shouldn't fall out, so you shouldn't be walking around and have the pessary fall out. And it shouldn't block bowel or bladder function. So it shouldn't be so big that you're unable to urinate or that you're unable to have a bowel movement. So typically in the office, we put the one in that we think is the right size. We have the patient do squats and different movements to make sure it's not easily sliding out. And then we have them walk up and down to make sure it's comfortable, and then use the restroom to make sure that they're able to empty their bladders. And as long as all of those things can be done, then it is deemed to be the correct size. And then we give it to them, and then we usually see them back pretty quickly afterwards to make sure that there's no problems with it. And we teach people how to take it in and out. That being said, I have plenty of patients that are not able to take it in and out themselves. And in those individuals, we usually see them back in the office anywhere between every 4 weeks to every 4 months. And that interval of time is typically dictated a little bit about on the body's response to having a foreign body, because the biggest risk factor with a pessary is going to be a foreign body discharge, meaning like kind of getting this like yellow or white discharge as your body's reaction to having something there in the vaginal area. We can try to combat it by using different like pH acidifiers and vaginal estrogen and other things, but nevertheless, it sometimes can happen anyway. And so for some individuals, they seem to not develop it very easily. And so every 3 to 4 months is a perfect amount of time. For others, it seems like it happens pretty easily. And so we have to see them more often to avoid having a significant amount of discharge.
And in terms of the pessary, so in terms of hygiene, you just, if someone were to take it on their own, just soap and water, clean
Yep,
it and store it.
exactly. So just hot soapy water. So there's some people who use them honestly just for like specific things, like going to the gym or doing something like or gardening or whatever it might be, where they might be vulnerable to feeling the prolapse. And if that's the case, they'll just wear it for a short period of time, and then you just take it out and wash it with hot soapy water. There are some other individuals who wear it like for a week, take it out and then clean it and just do it like that too. Some people will wear it only during the day and then nothing at night, and that's fine as well. It's kind of a personal preference on that, but yes, just hot soapy water is sufficient. You don't have to do anything else. Technically speaking, the pessaries can be like put in boiling hot water and other things. It's not going to hurt the integrity of the pessary. We autoclave them here, so they get fully sterilized, like through a regular sterilization procedure if a patient wants us to, but it's not necessary.
Okay. Very nice. Okay, thanks for sharing those images.
No
It was really
problem. So
helpful.
just real quick, I'm going to just show you some more things, only because they're on the market and people might hear about them. One of them is called the Impressa by Boys, and this is not intended for prolapse, although I've had some patients pick it up for that purpose. It's intended for stress urinary incontinence, and it's sort of like a funny shaped tampon that's very consumer friendly in the sense that you can put it in yourself. It again is really intended for stress urinary incontinence and not for prolapse, but I've had some patients come see me who have been using it and like it. This can't stay in for very long, similar to a tampon that's like an 8-hour max. And so for some people, they like it for a specific activity. And it does help a little bit with kind of very mild prolapse, but it's mainly intended for stress incontinence. And then there's another version of this that is like a, so these ones are disposable. And these ones are, this one's like a pessary, except for it's intended to be sort of consumer friendly in the sense that you don't need to see the doctor to fit you. You reach out to this company and they'll send you 3 different sizes and you try them out. This is also for stress incontinence, but I have had a couple of patients with mild prolapse use it and like it because it does kind of hold the bladder up a little bit too. And this one is a very similar idea to all of the others where you put it in and it should not fall out. It should be comfortable. You need to be able to urinate. But it has a little handle, which kind of makes it a little bit easier to kind of hold out yourself than some of the other ones. But again, it's intended for stress incontinence, but it may be helpful for sort of mild prolapse.
And
So
to clarify, stress incontinence is when you have some urinary leakage associated with an increase in pressure, which could be coming from a cough, sneeze, laugh, getting in and out of your car, and so forth. So that is what the stress incontinence is. Okay, and another question here. So we had touched on surgical candidate versus non-surgical candidate before. Now, let's say someone's a surgical candidate for pelvic organ prolapse management. Would you think physical therapy would still be necessary?
So I think we all feel that it probably is very helpful regardless, whether it's in the pre-op or post-op time period. The studies have been really mixed on this. And it depends on, a little bit has to do with how the study was done and the groups in which they looked at and the training of the physical therapist. So in some studies, they've shown that actually it is quite helpful. And other studies, it's been sort of, there's been no difference between the groups that got the, we're going to call it perioperative, meaning like around the time of surgery, either before and after, or just after physical therapy. They haven't shown that it's been necessarily beneficial, but there's been some question about the quality of the, I don't want to say the metrics, but a little bit of quality of the study as far as the groups in which the patients were getting physical therapy, the type of physical therapy, and some of the other metrics they were looking at. In the one study where they feel like it was actually really well done, there was a benefit shown, but it's really short time intervals. So it's hard to tell. It's hard for us to know. Logically, yes, it would make sense because it will only help you to have an awareness of your pelvic floor, to have a sense of how to not put extra pressure on your pelvic floor for surgery. And there obviously are some pelvic floor symptoms that are not anticipated to get better with surgery. So some people may experience an improvement with urinary frequency after having pelvic organ prolapse surgery. But the goal of the surgery is to put the organs back in their normal place. It doesn't necessarily result in a resolution of some of the symptoms they had developed.
That's a great point. And I think too, with physical therapy, something that the research does support. I have a study, the name of the study is Can Pelvic Floor Muscle Training Reverse Pelvic Organ Prolapse and Reduce Prolapse Symptoms? And this study is a randomized controlled trial that did support physical therapy increasing quality of life in terms of reduced frequency and bother of pelvic organ prolapse symptoms. So overall quality of life with living with a prolapse and not feeling those symptoms as intense. Physical therapy can definitely help with those symptoms in conjunction with overall. I think there's mixed reviews and mixed research with the grading of prolapse. But this study here supported increased bladder and rectum elevation. Now, obviously, it's going to depend patient to patient as everyone presents differently with tissue descent, but also overall factors in what might make someone more successful with PT versus PT plus other options and surgical intervention as well. So I definitely think in terms of the prolapse grading, there can be some success, but also it'll depend patient to patient too, with how well are they able to respond with non-surgical options in terms of that prolapse grading and support. What do you think, Dr. Mellano?
Well, and I think you bring up a really good point because you have to know yourself, right? So if you're somebody that, if I give you a set of things to do, and I say, if you do these 3 exercises every day for 15 minutes, and we check you in 12 weeks, we check you in 16 weeks, you're going to notice a difference. And you're somebody that knows you're going to do that, you're an excellent candidate for physical therapy. Because a lot of studies have shown bladder improvement, bowel improvement, all of it does improve, but you have to know yourself and know that you're going to do the treatment prescribed. Versus there are some people that are like, my life is so crazy, I barely brush my teeth every day. That person may not be the perfect candidate for doing the physical therapy. And you just have to kind of know yourself as well. Because I've had patients that really want to do physical therapy, and I'll see them 4 months later and they're like, I never went. I'm like, okay, well then clearly things didn't get any better if you never win. And then I have other people that are like, if you give me a homework assignment, I will absolutely do it. And they get a huge benefit out of physical therapy. So I think you bring up a good point that some of these studies may be mixed, just having to do with the fact that some patients may adhere really well to these regimens and other people don't. In my opinion, if nothing else, if it teaches you an awareness of your pelvic floor so that even in the post-operative period, you don't make yourself more vulnerable for prolapse recurrence, I think that's nothing but helpful. So if there's nothing else to get out of it, if you get that out of it, that's super helpful from my side.
Absolutely. And I think too, with physical therapy as pelvic floor PTs, we acknowledge the functional aspect of why these exercises matter and what you do throughout the day. And so just like Dr. Mellano and I had touched on the concept of pressure management with the pelvic floor, if we can just improve the way you're managing pressures throughout the day. So if you're someone that tends to hold your breath with certain activities, or with getting in and out of your car, or with getting up from a chair, things that you do already throughout the day, if we can just optimize the pressure management there and include the pelvic floor in activating prior to doing those activities that might increase that intra-abdominal pressure, causing the pelvic floor to work a little bit harder, just changing those things that you're already doing throughout the day will also make a difference in terms of how those organs and how the prolapse is being managed and supported. So in combination with exercise, trying to address those things that you're doing throughout the day and making those things even better will help with overall creating a more holistic and supportive picture for how do we manage pelvic organ prolapse with physical therapy. Because realistically, at the end of the day, 3 sets of 10 is not going to make up for what you do for most of the day. And so if we can really capitalize on the things that you're doing for most of the day, that you're doing day in and day out, and really increase the way that your pelvic floor muscles are supporting your organs as well as you upright. And we can really capitalize on those activities that you're doing day in and day out and see the exercises as supports, but also ways to strengthen the pelvic floor muscles. both of those meeting together can really create a more sustainable and holistic picture for how can we best support the prolapse in conjunction with exercise, but also your day-to-day activities that you do constantly. So that is a great point with the candidate for physical therapy that you had touched on, Dr. Mellano, with someone who will do their things that, you know, they want to do for homework and be consistent with that versus I was referred to physical therapy 4 months ago, but I never went.
Yeah.
But as physical therapists, you know, we are so willing to work with the patient and we're so willing to work with you and what your goals are and what your bandwidth is in terms of what are you willing to do and what are you willing to put in effort to create a more supportive picture for the prolapse, but also what are your goals and what's important to you and how can we help you? So every patient, and I know Dr. Mellano too definitely experiences this too, but every patient presents differently and all of your goals are going to be differently. And so having a provider that's really on your side for really making sure that we're able to meet here and acknowledge and appreciate the goals that you have and lift up together versus the physical therapist telling you to do all these exercises, do X, Y, and Z, and trying to pull you this way when we can just both meet here and move this way together, because that's really what's going to create a more sustainable and supportive picture for that patient. And I think every patient is different and unique in their own way. And so being able to do this and move together, we're going to heal really nicely that way. So, in terms of big takeaways, tell us about your big takeaways from our conversation today, Dr. Mellano.
I think that the most important thing with all of this is, yes, there is an anatomic issue when there's prolapse. And yes, you can have symptoms associated, either related to bladder, related to bowel. But truthfully, for you, for me, it's most important to listen to kind of what the patient has to say as the degree of bother and what's bothering them the most. I mean, there's good studies to show that 40% or more of females that are postmenopausal have prolapse. But that doesn't mean that 40% of females present with the complaint of prolapse. That's just what we see when there's all comers get looked at. Some people have no symptoms and no bother, and other people have significant symptoms and significant bother. And trying to figure out what is the most bothersome part and kind of addressing that and helping discuss the options, because it doesn't mean you have to have surgery or there's nothing we can do. There's obviously degrees in between that are really helpful for people. So kind of our optimal goal is to have patients be able to live their best quality of life and be least bothered by their pelvis as possible. So I think that's the ultimate goal. And how we can help you in getting there is sort of our goal as providers.
Absolutely. Absolutely. I think that is a great thing to think about in terms of our pelvic floor and our pelvis shouldn't really bother us throughout the day. But how can we lessen that and make it part of our body and make it so that it is a functional part of our day-to-day moving and living without having to think about it? In terms of questions, does anyone have any questions? We have about 5 minutes left, and we will have a Q&A at the end of the month to take any of your questions. So if you had put any questions in the chat box, or if you have any questions that you want to send over, we are more than happy to answer them at our Q&A. But for now, we have about 4 or 5 minutes left. Does anyone have any pressing questions for us?
Well, I have it's more of a curiosity. It is what it is, but I have had like mild, I guess, pelvic prolapse for years. And then about 8 years ago, and I was also using a estrogen ring separately, because of postmenopausal issues, and had been using it for a couple of years. So I was in a car accident where I was hit really hard from behind, and I really hurt my back, and concussion and whiplash and all that fun stuff. I don't believe in coincidences. After that happened, I could no longer wear the ring. I had to go to the cream because the ring kept falling out. And I'm thinking, what the hell happened to me in that accident? Do you think that is it a coincidence? And please tell me it was a coincidence, because it'll really depress me to think that that accident made my situation worse, but it was the craziest situation.
I think that's a very challenging question to answer without knowing you before and after the accident.
I know.
And if you want me to tell you it was a coincidence, I'm happy to tell you that. I don't know what during the accident caused such an anatomic shift with you that all of a sudden the estrine is no longer able to stay in very well.
Okay.
Estrine, we do know, can help for, it's kind of a twofer. It helps for the vaginal estrogen because that's very helpful for bladder and other symptoms. But it also, if you have mild prolapse, can be really helpful for kind of just keeping everything up. So it has that side benefit. But I don't know what shifted with your pelvic anatomy that causes it to now fall out. But we're going to just say maybe there was a slight shift in the bony anatomy that is preventing it from staying in place. But I'm not sure.
Okay.
Sorry.
Yeah, I agree with that. You know, there could be a slight shift with the bony anatomy. I'm going to take it as a coincidence too, because we don't know your history pre and post, but also overall orthopedically, we don't only have the pelvic floor that's supporting. There's a lot of other supports there in terms of your hips, belly muscles, all of those muscles that also provide support there. And so orthopedically, if there was a shift in bony anatomy and how everything's working together in that sense, that could play a role, but I think it's hard to give you a clear answer right now since.
What was even crazier, and you guys are the experts, I wasn't very impressed with this doctor. It's a long story, but he's the one that asked me if I had any issues with, you know, gynecological after the accident. And I'm like, what? As a matter of fact, it was the weirdest whole thing. I mean, he was a weird doctor, so who knows? But he's the one that brought it up. And then I thought, as a matter of fact, I did. And then nothing came of it. We didn't pursue it. Poo-pooed it after that. But I mean, he's the one that brought it up, and then, so it's just crazy stuff.
Interesting.
Yeah. So.
Anyone else have questions?
Hello, can you hear me?
Hi, yes. How are you?
I'm good. I love the PT at Women's Advantage, and I went for a while, and it taught me a lot about my own body. I just thought it was terrific. And
Oh, I'm so happy to hear that.
you know, when this situation of having to be home so much is over, I would go back. I am a person who in the past was prone to urinary tract infections. And so I've been cautious about continuing my exercises while I'm at home in, you know, during the pandemic, because, you know, I need to limit how many places I go, how many doctors I go to, and all that kind of thing. So any advice on that, continuing the exercises, you know, during the shutdown?
Yeah, absolutely.
When you're out at home alone. Yeah.
Yeah. So right now we're doing telehealth. So telehealth and in-office care is an option, and telehealth would look exactly like this. We're able to talk and move together. But you said you were a patient before the shutdown. So whatever exercises that was helping you before, definitely you can continue with them at home. And if you feel like you would like a reevaluation to update those exercises and work with where your body's at right now, we would be more than happy to do a reeval over telehealth to see what we can do to update those exercises for you so that where you're at right now, we're able to match where you're at right now and lift you up from there.
Okay, and the whole issue of urinary tract infections with having a pelvic prolapse, is there any connection there or not? I guess that's my question.
Yes, Dr. Mellano, can you touch on that?
Yes, absolutely. So with prolapse, there's first of all, like recurrent infections are multifactorial. They can be from many different reasons. But with prolapse specifically, if you are retaining urine, meaning like if you're not emptying all the way and you have urine stasis, so it just kind of sits there, it's like a perfect environment for bacteria to set up shop. And so if you do have an issue with significant urinary retention, then that actually may be motivation to either continue your physical therapy or consider a pessary or something like that. If it's not an issue, if that's not the reason why you're getting an infection, and if the infections are more just due to vaginal pH and some other things, then the prolapse itself is not necessarily significantly impacting it. So prolapse in and of itself doesn't, it has to do with the urinary retention associated with it, or if people are having issues with bowels, or they're having fecal issues or urinary incontinence or other things. But the actual position of the bladder doesn't necessarily make you more predisposed to infections.
Okay, and I mean, I've been at home since March, and I haven't had a urinary tract infection.
Yay,
So
knock on wood, please.
yeah, right, exactly. So I hope that I think you've answered some questions for me about how what the connection would be, and it's not really a big concern for me. So, but I wanted to know, because we all have to have a lot more information to take care of ourselves when we're at home like this. So thank you. Thanks a lot.
Dr.
Hi,
Mellano, can I?
Jenny.
Hi, guys. I just thought I would pop in and speak to UTIs as well. So, and Dr. Mellano, I'd love to hear what you think about this as well. But there was a fairly recent study in the last 2 years about women using topical estrogen and decreasing the frequency of UTIs, just urinary frequency as well. And then, and actually it was topical estrogen with physical therapy, and then topical estrogen, physical therapy, and vaginal probiotics. And they showed the group with vaginal probiotics actually had the best reduction in UTIs as well. So those are some options to think about. But also we think about if women specifically have some persistent constipation, that also leads to an increased risk of UTI. So we always look at bowel health as well when we're looking at somebody with those symptoms.
Okay,
Yeah,
thank you.
There's really good data to say that using vaginal estrogen, if you're a candidate for it, decreases your risk of an infection, just that alone, by almost 50%.
Okay.
So that's a pretty significant impact.
Yeah.
And so, and vaginal probiotics have been shown to be more helpful than oral. I mean, there's some kind of easy things, well, not easy things, but there's some things to be said for some of those things for sure.
Okay. Now, I'm glad I signed up for this. I'm learning a lot. Thank you.
We're happy to have you here too.
Thank you. Thanks.
Dr. Mellano, could you speak to whether somebody needs to be using a topical estrogen if they wear a pessary long-term, if this is someone premenopausal versus postmenopausal, kind of what your recommendations are there?
So premenopausal, not necessary, but postmenopausal, it's very helpful. You don't have to use it, and I have patients that for whatever reason sometimes either can't or don't want to, and that's fine, but it is very helpful for just vaginal skin health and the ability to tolerate it. The pessaries rub, and if your skin is really fragile or really delicate, it can cause more risk for like ulcerations and other things. So the vaginal estrogen is very helpful with that. It's also really helpful for the pH, which is what the whole infection and everything else comes down to. The vaginal pH when you are premenopausal tends to be really low. It runs around a 4, 4.5, which is really low. If neutral is 7, it's pretty low. As women have less estrogen in their body from menopause or whatever else, it tends to go up. It doesn't necessarily go all the way up to like 7, 8, 9, but it tends to go up higher than where we like to see it as a protective type environment. So for lactobacilli, which are good bacteria that help protect you from getting infections and help protect you from getting sort of either bladder or vaginal types of infections, we like to see the pH a little bit lower. And so with the pessary specifically, you have a foreign body in there. It is nice to both help keep the skin a little bit more supple and a little bit thicker, but also to help prevent infections. So if you can use it, it is highly advisable. But there are patients who can't, and they still use a pessary, and it's fine. It's just that it makes it a little bit, it works a little bit better if you can.
And I am seeing one question in the chat. How do you describe the different scale of prolapse, and at what point is surgery recommended?
Okay, so I think we kind of touched a little bit on this, only in the sense that like surgery is almost always dictated by the patient. The stages, there's 2 different systems, and this is more academic than really matters, but there's 2 different ways to describe how far the prolapse is coming down the vagina. We tend to use stages just because that's what studies use, and so we kind of try to follow suit. But essentially, stages 0 through 2 basically are considered no prolapse to like moderate, and 2 only gets you about 1 centimeter outside of the vagina or outside of the hymen. And so after 2 is stage 3, which gets you almost all of the vagina out, and then stage 4 means the entire vagina has come out. And different organs pushing, different walls pushing. You describe the stage based on what you see. But essentially, for stages 0 and 1, which means very little prolapse at all, we would not recommend surgery because, like I said, risk benefit would just not be there for that. Stages 2, 3, and 4, you're a surgical candidate, meaning you could have surgery if you wanted it. But as we had talked about, there are some other options for treatment. And so it's really dictated on you and what you want to do. Hopefully that answered the question.
I believe that is all the time we have. Thank you so much, everyone, for coming. We're so happy to have each and every one of you on here. And Dr. Mellano, can you just share with us where can we find you?
I am across the street. I'm across here from Women's Advantage. I am kind of kitty corner from Little Company of Mary. We are here. We are happy to see anybody that has any sort of pelvic floor issue and happy to help direct your care in whatever way we can. But I'm here in Torrance. I'm on Lake Torrance and Earl. So that's where I am.
Awesome. And at Women's Advantage, we really value that transdisciplinary collaboration amongst our medical community. So for those patients who would like to see Dr. Mellano or those patients that are already coming to PT, just know that we do talk and we do collaborate because that transdisciplinary collaboration is so key, as we just talked about, especially with pelvic organ prolapse management. So just know that we are both on your team and working together too.
Absolutely.
And Jenny, do you have anything else that you would like to say before we close out here? I think your mic is off.
I really appreciate both your time and expertise that you shared with us today. So thank you very much. And thank you for everybody who came and just spent the last hour with us. And come again. We will be talking about menopause next month with a nurse practitioner that specializes in that. So that should be a good chat happening again next month.
Awesome. And Jenny, with the Q&A at the end of the month, how can people send in their questions to get answered for our Q&A?
They would have to probably come on live on our Facebook feed, although this recording is going to be on our Facebook page as well at Women's Advantage Men's Optimal Health Physical Therapy. And so if you posted questions just below that video, then that's an easy place for us to be able to find them. And then our staff, 2 of our PTs, go live the first Wednesday and the last Wednesday of every month and talk about our monthly topics. So this month being bladder and prolapse. And so at the beginning of the month, we talked about some research studies, and then we do an interview of one of our local experts who we love. And then the end of the month, we finish up with any Q&A that we still have some burning questions waiting for us. So we will be live the last Wednesday of the month at 11:30. And so 2 of our therapists will be taking care of that.
What's the name of the Facebook page?
Women's Advantage Men's Optimal Health Physical Therapy. I know it's a mouthful.
Thank you. Thank you.
You're welcome.
All right. Thanks so much, everyone, for coming. And like Jenny said, if you have any questions, feel free to tap into our Facebook page, and you can even just post your questions as comments too, and we can also take them from there for our Q&A. So thanks so much, everyone. And thank you, Dr. Mellano, so much for your time. We are so appreciative.
Thanks for inviting me.
Yeah.
I love talking about this stuff, so thank you so much.
Yeah, thank you. All right. Take care, everyone.
All right.
Thank you.
Thank you.
Bye-bye.